Hello again, Dr. Welgan here. We are now at the end of that series on gastrointestinal disorders. Remember, we talked about irritable bowel syndrome, colitis, which is an inflammatory bowel disease, and Crohn's disease. Again, another inflammatory bowel disease. We move now up the gastrointestinal tract to the stomach, to a condition here that, as a psychophysiologist in gastroenterology, I've become all too acquainted with this condition. I have studied it at UCI and provided treatment protocols to my patients who have this condition. It is called Gerd, gastroesophageal reflux disease. For those of you who have it, and there is a large percentage of patients that are seen by gastroenterologists that have this diagnosis, it's estimated that about 40% of the patients who visit gastroenterologists present with Gerd. It's a condition here that is quite dangerous if left untreated. It really involves the following. For those of you who have gastroesophageal reflux disease, you already know it. You're probably on some kind of medication for it. But for those of you who are relatively unfamiliar with this condition, I'd like to discuss it with you briefly. I want you to keep in mind here, there's a good deal of medical research in this condition, trying to determine how to actually, what causes it, and how to treat it. But as a psychophysiologist, you must keep in mind, I look at this condition from the point of view of a psychologist, an experimental psychologist, and one who is interested in trying to produce some kind of self-management tool for the symptoms associated with this condition. Okay, with that in mind, what are we looking at? Well, gastroesophageal reflux disease, it's the stomach. Well, here we go again. Wonderful artwork here, huh? That's actually a stomach. Now, for those of you who may or may not know, that is a live organ. In fact, if you were to hold it in your hand, you could probably see it undulating. Okay? It's motility. The stomach does an awful lot of very interesting things. If you ingest food, deposit it in the fundus or the body of the stomach, a lot happens, as you probably know. There is a bed of cells called parietal cells in the fundus of the stomach that actually begins to produce copious amounts of hydrochloric acid. Hydrochloric acid is a very corrosive agent, as you know, and one of the reasons why hydrochloric acid doesn't actually burn right through the stomach wall itself is a protective coating called mucosa. Okay? That protective coating here produces a mucus that actually prevents the hydrochloric acid from actually reaching the stomach wall. However, in the case of Gerd, the acid does something really very interesting. It flushes up against the esophagus. There is a sphincter right here. It's called a lower esophageal sphincter that actually closes in the individual who does not have this condition as the acid and motility begin to produce their work, and that is the breakdown of those foods into what's called chyme. And the chyme has to actually be sufficiently liquid in order to pass in through the pylorus into the duodenum. And it has to be of a certain pH or acidity, okay? However, the problem here with Gerd is that the acid, hydrochloric acid, flushes up against that lower sphincter. Now, it should close, but it remains open and acid flushes up into the esophagus. Well, that's a dangerous move because the esophagus is not protected like the stomach, and it's exposed to that acid. So it tends to happen here with a chronic recurrent condition like Gerd. Remember, this is just not a single event. It's a condition that is persistent over time. That hydrochloric acid flushing up into the esophagus begins to produce some really interesting problems here. It'll inflame that tissue, the epithelium of the esophagus, be a redness to it. It also begins to affect the sphincter itself, which is elastic. It's a muscle, okay? And you get enough acid into the esophagus and across that sphincter, the sphincter is also subject to the effect of hydrochloric acid, and it begins to create scar tissue and stays open. It loses its elasticity, and the contents of the stomach then begin to really have an effect on the esophageal walls. There are several different conditions that result from that if not treated. And we can talk Gerd syndrome. There are a couple of others that I can discuss with you, but it's kind of dangerous because it can actually lead to esophageal cancer. It's in some patients here, so you have to be really careful about that. So what are we looking at here with regard to this condition? First, if I can, acid. Motility. That stomach is moving and actually enabling that acid to flush up against the lower esophageal surface, the wall of that sphincter. Motility. When I say acid, we begin to see a high production of acid in some patients, okay? But it doesn't take too much. Okay. So we're looking at acid, motility. What causes this? Well, really, they don't have a complete answer, but they do know what can contribute to it, okay? Smoking. I'm going to write this down. I'm going to turn my back on you. Here, smoking. Obesity. Certain foods, particularly spices. There are several different types of foods here. You have to be a little careful. In fact, if you have Gerd, you know the foods that will begin to produce symptoms of Gerd, and I'll talk to you about those in a minute. Okay? Now, as a psychologist, if you take a look at the medical literature, you'll take a look at everything the physician is interested in. But those of us who are in this business, are interested in something else. And the psychological factors, psychological factors that affect GERD. We're going to talk about that. I want to go back. How do you know you have GERD? First of all, pain. I'm going to change this for this. Generally, you'll feel pain, okay? Sometimes you feel like you're having a heart attack. Your physician will kind of rule that out, and it's got to be something else. Very often, it is that flushing up against the esophagus, okay? Nausea. Vomiting. A bitter taste in your mouth. Taste. You'll notice you'll have kind of an acidy, bitter sense, particularly if you wake up in the morning. You may have that. Sometimes recurrent and chronic coughing. That's coughing, okay? Hope you can read it. There are a lot of other symptoms. Not uncommonly, some of these symptoms occur at night. You'll notice if you have sleep apnea. Sleep apnea. You can wake up with this type of sensation in the morning. If you're sleeping in a prone position, where the acid has a greater tendency to reflux into the esophagus, if you're lying sleeping at night in this fashion. And commonly your physician is going to say, listen, prop your head up with a pillow, create an angle here so it is not that easy for the acid to reflux into the esophagus. Okay? Sometimes this condition can be associated with other motor conditions of the gastrointestinal tract, and that has to be ruled out by your specialist, medical specialist. That doesn't occur in all cases. However, you can have GERD and not have any other symptoms like irritable bowel, for example. So you have symptoms that, quite frankly, let you know that you're having difficulty here. They can be quite severe, actually affecting your ability to function at work or elsewhere. Okay? It's a range of severity, actually. Okay, but dangerous enough. You don't want to let it just live with it. Okay. So, in my work over here, I was interested in knowing, are there differences in patients who have GERD in which the way they cope with their lifestyle, and personality, coping characteristics may have some effect. Ran a study, presented this a number of years ago at an international conference of gastroenterologists in Geneva. When compared with adults who did not have GERD, we found no differences in personalities and coping styles between those who didn't have GERD and those who did. So coping styles do not necessarily distinguish GERD patients as opposed to others. The personality characteristics of GERD patients, quite a lot has been studied here. We're finding that depression, anxiety, chronic stress. Talk to your doctor about chronic stress. You'll probably hear him say you've got to do something about your lifestyle and change it. What he really means is, stop smoking, cut back on your drinking. If you're a moderate to heavy drinker, you probably want to check with your doctor on that. It really aggravates the condition. And alter your stress levels, okay? So we're seeing those kinds of associated psychological factors with many of the GERD patients that I have seen privately and over here, and you'll find that even in the literature. But nothing to really distinguish a GERD patient from an irritable bowel patient, from a migraine patient, from anybody who has any other psychological or psychiatric condition. In other words, they very often share psychological characteristics with those who have other conditions, or can be even normal and have just very non-clinical characteristics of anxiety and depression and stress, okay? So we're not seeing a great deal of individuality with regard to the psychological profile of our GERD patients. Quite a mixture of them, as a matter of fact. As a learning theorist, I'm interested, of course, in how one may well learn how to be a GERD patient. Okay, sounds weird, huh? How does one actually learn to actually produce so much acid that it refluxes into the esophagus? Okay, sounds kind of weird. Your physician will say, no way. Okay. But what I have done over the last 35 years in working with GERD patients here, and my private practice and in the Center for Behavioral Medicine and Gastroenterology, I've found that if you employ a very strict learning theory-based behavior modification protocol in the treatment of patients to treat the symptoms of pain, vomiting, this, treating those symptoms, I've been able to actually produce a very successful change in this, a patient who has achieved an ability to control these symptoms in a behavior modification program, okay? That's a biofeedback-based behavior modification program. It is systematic. My program is a 3-phase program, and people actually have reported over the years a significant improvement in the management of this condition. That's the reason I'm talking to you today, because the medications that you're taking here, from antacids to H2 receptors, and these are medications that actually prevent the formation of hydrochloric acid to some extent, and proton pump inhibitor medications are the ones that are being used today. There are others that always have some concern for the side effects of these medications, okay? So it's not that medications shouldn't be used. As a psychologist, I'm always interested in how you can approach it from a behavioral point of view and actually reduce your risk, the side effects of medications that you may have to take for this condition. Gerd. Now, in my program here that I have talked to you about over time, there is a whole series of treatment programs set up for my gastrointestinal patients, from irritable bowel, inflammatory bowel disease, and I have a treatment program for patients who have GERD. Before we conclude this series, I'm going to invite you to, if you have further questions about how to proceed with any kind of intervention like this, a treatment protocol, I would like you to you can email me, Peter R. Welgan, ph.d, the dog, at cox.net, and I'll be happy to talk to you further about it. Or you can attend one of my orientation meetings that you'll find on my website. If you're a GERD patient would like to learn more about the self-management of symptoms associated with this condition here, you can join us for the orientation seminar. Just check on my website. You'll see the orientation dates, and you're welcome to join us. In the meantime, as this concludes our series on gastrointestinal disorders, I'd like to thank you very much. We're going to be moving on to some additional lectures here. I hope you'll find it enjoyable. But in the future, if you're interested in pursuing any of these treatment programs for any of the conditions that you have, please give me a call, okay? Okay, stay tuned. I'll see you tomorrow. Thanks.